For sake of time, I'd like to move to the next section, which is our featured speaker, Kim Slocum. And Kim is the president of KDS Consulting, an organization devoted to helping healthcare organizations find strategic, sustainable solutions to the business challenges they face. He's worked for over 30 years in a variety of healthcare, pharmaceutical, and biotechnical firms. Kim is deeply involved in healthcare IT. He is a fellow member of HIMSS, former member of the HIMSS Board of Directors, and recipient of the HIMSS 2005 Board Service Award. He's also served as a member of the HIMSS Advocacy and Public Policy Steering Committee, as well as its Auto Identification and Barcoding Task Force. He's also a member of the faculty for the HIMSS Annual Conference, helping to teach a course called Health IT 101. And that is designed to introduce individuals to health IT and how policy and IT intersect. Kim is a frequent speaker on issues related to the future of healthcare, and that's the reason we've invited him to speak, and we're glad to have him join us today. Welcome, Kim.
Thank you, Aaron. Thank you very much. And thanks very much to all of the Formfast folks for inviting me to join you today. As Aaron suggested, I am a policy strategy person. I work mostly at the C-suite level in healthcare organizations, but I also have a deep and abiding interest in information technology and about 20 years of background in that community as well. So what I want to do for the next 30 minutes is tie those two disparate threads together while I talk about responding to the healthcare reform situation and how hospitals can thrive in the new environment. First of all, I think I lose my policy wonks license if I don't remind you that we are at the end of business as usual for hospitals and health systems. The heads in beds model is either dead or rapidly dying, and that's because U.S. healthcare cost growth had been running at about 2 to 2.5 percentage points higher than the overall rate of growth in the economy for the past 4 to 5 decades. Astonishing as this may be for you, something like 3/4 of all the real income gains that U.S. households have attained over the last half century went to pay for health care, and that has affected people's standards of living. Employers who provide health care for about half of the U.S. population have been spending more on those benefits than they made in profits from their core business operations. And many had begun to reach the end of their ability to continue to underwrite coverage, certainly a very dire turn of events. If you've been following the debate in Washington over the past year or two, you'll be aware that the single biggest long-term threat to the public sector financial stability of the United States is the growth of the Medicare and Medicaid programs and the spending associated with them. That's on the cost side. If we look at the access side, until recently we had more than 50 million people uninsured, folks with no regular access to care. And just this week we were reminded again that outcomes of U.S. healthcare in some categories rank the U.S. on par with third world nations. So this is not a track record, I think, as a collective country that we can be proud of. So in that regard, I think we need to look at the passage of the Affordable Care Act about 4 years ago as really a national reaction to these long-standing problems and a response to the unsustainable system that we've had. Now, of course, if you follow the headlines over the last 6 to 9 months about the exchanges and the like, changes in coverage availability garnered most of the headlines in the press. But let me suggest to you that changes in payment mechanisms for providers and encouragement of very serious delivery system reforms that are baked into the law may wind up being its most long-lasting legacy, particularly for those of you on the provider side. So I believe that providers have to face these changing realities and adapt very quickly. Now, the first reality you have to adapt to is the fact that consumer cost sharing has doubled in the past 5 years. This is an analysis done by PricewaterhouseCoopers, the consultancy and auditing firm. What you're looking at is the cost of in- and out-of-network deductibles for people with employer-sponsored insurance between 2009 and 2013. And if you look at the pie chart on the right, you'll see that deductibles for in-network services for people with employer-sponsored coverage now frequently exceed $1,000 for in-network and $2,000 for out-of-network coverage. So what does that mean? Well, it means that we are now coming to a point where the irresistible force is meeting the immovable object in healthcare. If you weren't aware of this, median household income in the United States is now at about $51,000. Median is half above and half below. And by the way, on a purchasing power parity basis, that number hasn't moved in several decades. So the average middle-class household in this country is pretty much where it's been since about the 1970s. As a consequence of that, many American households have less in savings than the amount of their health insurance deductibles. There was a recent report issued by the Employee Benefits Research Institute saying that 40% of all U.S. households had less than $1,000 in savings, and many of these households basically would have to go into debt to meet an unanticipated expense of $1,000 or more. Now, if we bring that down to healthcare, what it means is that people, in essence, are kind of rolling the dice every year when they face these $1,000 deductibles, and they're betting, in essence, that they do not need to use their healthcare benefits. Unfortunately, a lot of people lose that bet, and they often wind up with medical debt, which now affects close to 1 in 3 households in the United States, and increasingly is impacting middle and even upper income households. Most of the people who are caught in the medical debt trap actually have employer-sponsored insurance, and they're caught up in the cost sharing for covered services, which is exactly the last slide I showed you. Now, if this medical debt continues, and a lot of it winds up getting put on credit cards, it continues for more than a year or so, it is quite likely that that household will wind up with severe financial problems and can even wind up with personal bankruptcies. 40 to 60% of all U.S. personal bankruptcies on an annual basis are now caused or heavily contributed to by medical debt. And we have about 1 to 1.2 million of those in each calendar year. Once again, this differentially affects middle-aged households with employer-sponsored insurance. And as astounding as this may sound to those of you on the call, the average amount of medical debt owed that's required to put someone into bankruptcy court is only a little more than $17,000. So what does this mean for you as providers? It means that you're going to see a lot more bad debt. The average percentage rate of maybe 3 or 4% has gone up to 6 to 8 to 10% in some institutions these days. And as a consequence, you need a cohesive strategy and much more connected information technology tools to mitigate your revenue losses. Now, what do I mean by that? There's a robust online banking community. Your enterprise should be connected to it so that you can make direct access to things like patient health savings accounts. You also should be able to track online exactly where your patients stand in the progress of meeting their annual deductible obligations and what their benefit design looks like so that you know how much you should collect at the point of care. Ladies and gentlemen, if you're not doing that at the present time, you are suffering a significant revenue leak in your institution, and that's something you really can't afford to do in the harsher environment that we now face. Now, if we look at third-party payment, the traditional way that institutions in healthcare make money, we can see that there are changes there as well. Among many things that I do, I support Harris Interactive, the big opinion research firm, and their midterm healthcare forecasting service called Strategic Health Perspectives. And this afternoon, I'm going to share with you several slides from a survey that we did with hospital and health system executives a year ago in June, and show you how this is starting to impact you. So what you're looking at here is a question that we pose to these folks, asking them how much they earn on commercially insured patients relative to Medicare payment levels. And what we found is that in 2011, just a couple of years ago, 46% of our respondents said that they were getting paid 125% or less of Medicare, a relatively small premium. By 2013, that number had gone up to 58%. That's a gain of a quarter in just 2 years. I can tell you, because I spent a great deal of time with the employer community, they are pretty much done with the idea of being cost shifted to from the public sector programs. So if you work in an institution that has profited off that hydraulic of cost transfer from public to private sector programs, you will need to rethink your revenue model, because those days are rapidly coming to an end. Now, as a consequence of that, as a consequence of the provisions of the Affordable Care Act, of the consumer cost shifting, and the reduction, particularly in commercial payments, we see that the business model for larger providers has been changing over the past several years. Most providers, physicians and hospitals alike, have tried to move away from being a vendor, just owning an encounter, to at least owning a disease, a la groups like the Joslin Institute in Mid-America. And ideally, most most institutions now, the larger ones at least, want to own a population, and they want to be considered an integrated health enterprise, which of course is where accountable care organizations come in. Those, of course, were created by the Affordable Care Act. Now, what we also see is the number of accountable care organizations has grown pretty rapidly in this country. This is a survey from Levitt Partners. Levitt Partners was founded by Michael O. Levitt, who was President George W. Bush's last Secretary of Health and Human Services. His organization has charted that there are now 606 of these entities in the United States. Now, that doesn't sound like too many when measured against the thousands of hospitals that we have operating in this country, but remember that an ACO can encompass multiple institutions or even multiple hospital chains. So when we look at the Strategic Health Perspective Survey, we see that 43% of all U.S. hospitals now report that they're part of one or more accountable care organizations in the United States, and a fairly astonishing 25% of their revenues are being managed by ACO. So this has been a dramatic uptick in a very short period of time. We have another 41% of hospitals in this country saying that they're working on becoming an ACO, with 23% saying they're extremely likely to become one. And this, again, is a big jump in just the course of 1 year. So this, ladies and gentlemen, has become the new model under which most hospitals and health systems are operating. Now, the reason for that is because the type of payments and the way institutions get paid is changing pretty rapidly. Again, from the Strategic Health Perspective Survey, we asked hospital and health system executives to rate on a scale of 0 to 100, where 0 was a completely fee-for-service environment and 100 was completely capitated, where their revenue streams stood today. And as you'll see, they said collectively they scored at about a 37. But take a look at the bottom arrow, and you can see there's going to be a big jump over the course of the next 5 years. People will be more than halfway to completely capitated payments by about 2018, which would have been 5 years from the date this survey data was collected. So what this tells us is that healthcare information technology is the cornerstone of healthcare system success in the new environment. And this is the main thrust of my message today, and I want to delve into this in a little more detail, having set the context up for you. First of all, there are multiple surveys from Harris, from the Commonwealth Fund. They've been published all over the healthcare policy literature, showing that overwhelming majorities of system executives, we're talking 70, 80, even 90%, recognize the need for robust, interoperable healthcare IT applications and are investing significantly to upgrade their organizational capabilities. Indeed, it is common to see now that HIT is the single largest component of CapEx budgets in health systems and hospitals, and it's been that way for a while and is expected to continue for several more years at a minimum. There are basically 5 key areas where healthcare information technology is going to be required to perform. The first 2 of these are more traditional areas that we think about when we think about hospital IT: administrative claims and billing. This may seem like a fairly sleepy application, but of course, as I've just shared with you, given the cost shifting from consumers, this is an area where you're going to need to upgrade your capabilities. Departmental systems like radiology, pathology, and pharmacy have been a mainstay of hospital IT for many, many years. The challenge, of course, is that many of those applications were purchased and installed at a time when it was okay for them to be siloed and standalone. That is no longer the case. Institutions are going to have to break down those barriers and make sure that data can be extracted and moved to other places in the enterprise. We have, of course, 3 emerging areas of healthcare IT: the core electronic health record, health information exchange, which involves the sharing of information, and where the big money is going to be: data warehousing, business intelligence, and analytics. So let's take a look at what we're going to do, because healthcare IT, I think very specifically, is not just about boxes and wires and flashing lights. It's about solving enterprise-wide objectives. So what are the 3 critical tasks that HIT is going to be addressing over the next few years? The first of these is efficiency. Clearly, in an era when reimbursement is constrained, increasingly when bad debt's increasing, when commercial payments are being reduced, you want to substitute relatively inexpensive technology for costly labor every place you possibly can. And you certainly want to improve the reliability of operational information capture. It is critical that you avoid rework every chance you possibly can. That is exceedingly expensive to do in the era we are now entering. Second of all, you're going to have to improve your patient-level clinical effectiveness, and this really focuses on improving the care for individual patients through information sharing. The goal is to make sure that every member of an individual patient's care team is on the same page and has access to all the pertinent data in their medical record to be able to direct treatment. What this is going to do for you is improve your patient satisfaction scores, and those are intermediate metrics that control a lot of the bonus dollars that are now flowing to hospitals and healthcare systems. Finally, population-level health management, as I've suggested, is where a lot of the action will be over the next few years. This, of course, includes data warehousing and predictive analytics. This is going to be the primary platform to support performance metrics for outcomes-based payment, which, of course, is where the system is moving as rapidly as possible, as I showed you just a moment ago. It also, though, is going to be very useful for you internally to be able to measure and benchmark your internal providers and report to them on their care patterns. Finally, increasingly institutions are going to have to be able to identify the right treatment for the right patient in real time, report on potential care gaps to providers, and ensure that they make the right choices. And this is clinical decision support writ large. All of these capabilities will be absolutely pivotal to the success of healthcare enterprises in an accountable era. Now, one of the things that we see when we ask hospital and health system executives what keeps them awake at night is that the costs that they bear are the largest financial challenge that they face. In the Strategic Health Perspective Survey, 20% of executives called out cost by itself. Another 55 rolled it in with revenue and margins. So no matter how you slice it, about 75% of all health system executives say they're worried about costs in one form or another. I think the good news is that systems have now recognized the need to change their ways. And from the Strategic Health Perspective Survey, we got a pretty astounding finding last year. 71% of health system executives we surveyed agreed that they would have to learn to make money on Medicare reimbursement levels. Now, if you've been in hospitals or health systems for any period of time, you'll recall that the old metric was you just wanted to break even on these patients. But ladies and gentlemen, Medicare reimbursement is the new black in hospital and physician payment. So you're going to have to be able to make money at those reimbursement levels rather than just break even. Now, to accomplish this, 42% of our executives in the survey thought they would have to take at least 11% of their cost base out, and 10% thought they would have to take 20% of their cost base out. This includes both supply chain efficiencies and labor. Now, that, of course, is a very, very heavy lift, but fortunately, there are indicators out there that it is indeed achievable. About a year and a half ago, the Premier Hospital Alliance, one of the most prestigious GPOs in the United States, published an efficiency dashboard and looked at the average savings possible for a 200 to 300 bed community hospital. And you can see those called out a bit on the box on the right. $17.25 million was the average savings they thought that they could achieve. And you'll note that excess readmissions, which is kind of the poster child for inefficient hospital utilization these days, is called out by the potential cost per case. But I would call your attention to the line item at the top, inefficient processes, which all by themselves accounted for more than 1/3 of the potential savings possible. So it's not all that heavy a lift to be able to find a lot of money if you are willing to go out and look for it a little bit. Now, where are some IT-related low-hanging fruit areas where you can improve efficiency? Well, a lot of it is what you've been talking about for the past hour, hour and a half. Substitutions of electronic forms for paper, things like e-signature solutions, automating workflow, particularly commonly used templates, particularly things like auto ID barcoding of patients, equipment, supplies, and medications fit onto this list, and automatic data export. Ladies and gentlemen, I want to reinforce as strongly as I can, these are applications that have been proven to work. They have been documented to save institutions money pretty much any place they've been applied properly. So I would strongly urge you to be adopting these technologies to the maximum of your capabilities as quickly as you possibly can. They are the easiest and simplest ways that I know of for your institution to improve its efficiency. Now, if we move on to the more ephemeral or speculative areas, we find that most hospitals in the United States have now installed a core electronic health record system. This data dovetails pretty nicely with what we see from the ONC and other sources out there, but according to the Strategic Health Perspective Survey, we now have a little more than 80% of all hospitals with a core electronic health record installed. The problem that we have with electronic medical records generally is that unless they are connected to other applications, and particularly other medical records, the EMR, those letters, actually stand for empty medical record. So where do we stand on the progress of getting health information exchange up and operating? Well, unfortunately, this is kind of a mixed bag. From the Strategic Health Perspective Survey, we see that about half of all hospitals in the United States say they're participating in at least some form of information exchange. Most of those tend to be involved with public exchanges set up in their state or region. We find that larger hospitals, particularly those with more than 500 beds, are somewhat more likely to be operating a private exchange, the so-called walled gardens that we see very commonly in large health systems. But I think astonishingly, we are close to 50% of less than 500-bed hospitals who say they are not participating in any form of information exchange. Folks, this is a critical failing that's going to have to be addressed if you're going to improve patient care at the individual patient level and achieve those improved patient satisfaction scores. This, of course, is also the focus for the Office of the National Coordinator for the next year or two, as they've identified quite vocally. We also know that aggregate population-level health data is vital for the emerging ACOs. Now, about 2.5 years ago, the American Hospital Association released a white paper entitled Hospitals and Healthcare Systems of the Future. And the quote here at the bottom, I think, is particularly salient. It's not enough just to possess information systems or extract the important data. The ability of an organization to leverage the technology to perform sophisticated data mining and analysis in real time for continuous care improvement is critical for long-term organizational sustainability. Very, very strong words. So the question that I have always is, so how much progress have we made in the couple of years since this document was issued? Now, like a lot of you, I expect, I spent a number of days, about 4 of them to be exact, in dark meeting rooms in Orlando at the most recent HIMSS meeting back in February. And I listened to presentations from all of the leading ACOs in the United States to sort of try to get a benchmark for where they stood. Well, what we see is that high-level dashboard reports for critical system metrics are now appearing pretty much everywhere. These are things like occupancy and readmissions, and they're being reported to the C-suite on a daily basis. But the leading accountable care organizations have now increasingly moved on to other objectives. For example, they're trying to find their quote-unquote train wreck patients, those 5% of patients who will account for more than 50% of costs, because in an at-risk reimbursement environment, their costs will determine the reimbursement and the profitability for that institution. So increasingly, these hospitals and health systems are trying to coordinate their care, and they're finding, much to their surprise, that often it involves things that happen outside the enterprise, things like social determinants, like the support system the patient has at home. So a lot of these institutions have found that they actually need to start hiring social workers in order to make this a reality. Increasingly, they also want to find out where people are getting care. Because if you're at risk for that cost of care, you want to know, is this care being delivered in or out of network? And a lot of these leading ACOs are partnering with health plans to find out what kind of care is delivered outside the enterprise. And much to their chagrin, they're learning that 25% or more of all care is being delivered by out-of-network providers. This is a very expensive proposition in a revenue-constrained and at-risk world, something that the leading ACOs are now trying to address. Perhaps most interestingly, some of these most advanced institutions are finding that cost for the top-line patients, the very expensive ones, are difficult to compress, so they are now beginning to train their sights on the next level of at-risk patients, those who are sort of teetering on the edge of a potential catastrophic event, in an attempt, as one system executive put it, to move the mean. Unfortunately, that talks about the leading-edge institutions, but where do we stand if we look across more typical hospitals and health systems around the country? Here, the picture is not nearly so happy. From the Strategic Health Perspective Survey, we find that 43% of hospitals in the United States reported that they did not have data warehousing or analytics capabilities. This, ladies and gentlemen, is literally flying blind in a prospective payment era. Even those that were able to provide real-time clinical metrics to management, 36%, we see those numbers start to tail off when we begin to talk about providing information to providers in real time and identifying care gaps. So clearly, there's a lot of work left to do here. Now, if we look at the pie chart on the right about where hospitals and health systems are going to increase their capabilities in this area, 38% are partnering with health plans and bringing in claims data to do that. That's a very good idea because it is probably the fastest way to solve that network leakage problem. 46% are building their own capabilities in-house, 16% doing something else, and most of those, I believe, are probably partnering with the emerging analytics vendors that have popped up all over the landscape in healthcare IT for institutions over the last year or two. We also find that in their drive to become accountable, more and more hospitals have purchased medical groups. That number jumped from 62% to 74% in just 2 years in the Strategic Health Perspective Survey. And if you look at the box in gray on the bottom, you'll find some surprising numbers about who's being purchased. It's not just family practice or people that staff hospitals anymore, like general surgeons or hospitalists, but procedure-based specialists like gastroenterology and even hematology-oncology are now on the acquisition list. This suggests strongly, again, that over the course of the next several years, we will see more and more physicians employed by hospitals and health systems. Now that, of course, brings up the very difficult and challenging question of how best to integrate hospitals and physicians together. Here's a list of challenges across the bottom, and I've circled engaging physicians using your healthcare IT infrastructure, and this is a glass half full, glass half full kind of, a glass half empty, glass half full kind of response. 24% thought they'd done that well, 18% not so well. But if you look across the column footers, things like expanding your capabilities to serve newly insured patients, aligning physicians to your strategic goals, engaging payers and health plans, incentivizing your physicians, managing your patients more holistically, and engaging non-employee specialists, I would respectfully suggest to you that every single one of those integration challenges will be improved with better and more robust healthcare IT applications. In many regards, HIT is something of a universal lubricant when it comes to physician-hospital integration. So what's your taxonomy going forward? What are the things you really have to do as an institution to win? Well, I like to put this in, as I phrase it, in the 4 C's. My first is to capture data entered into the system by healthcare professionals or patients on a software-agnostic basis. You probably, if you're involved with one of these institutions, have a Tower of Babel. It's important that you be able to get this data and get it in standardized form. You're certainly going to need to connect to alternative news sources of medical data both inside and outside the hospital. This will include pharmacy data, freestanding labs, and even retail clinics. You're going to have to be able to coordinate the care between various stakeholders on the care delivery team to improve individual patient care. And as I suggested, you're going to have to collate and supporting major data warehousing and analytics efforts to measure and improve your enterprise-wide performance. So let me wrap this up. Well, I'm sorry, I left one out here. Let's talk a little bit about the road ahead. My friend and former HIMSS board colleague Dave Garretts from the advisory board company talked about this about a year ago at the business analytics workshop at HIMSS, where he said that most institutions today were at a descriptive level. They could talk about what had happened to them in the past and report on patient admissions. The leading edge institutions have now moved to predictive analytics. They can start to identify their high-risk patients and predict their capacity bottlenecks, but the winning institutions are going to have to be able to optimize their capability, be able to choose therapeutic approaches for individual patients, and use a scalpel rather than an axe to cut their costs, and these, of course, are prescriptive analytics. So let me answer the question I posed at the outset of my remarks. How do you thrive in the new environment? Well, first of all, you have to accept that maintaining the status quo is not a viable option. The old-style business model that served hospitals and health systems for the past half-century is largely behind us. And as management consultants of all stripes will say, solving a problem is half accomplished by recognizing that it exists. So you do, if you have not already done so, have to assemble a sustainable delivery system that focuses on coordinated care and better outcomes. That is the heart of the accountable care organization movement. you're going to have to develop the necessary supportive business processes. This is not always glamorous work, ladies and gentlemen. It's not the stuff that garners a lot of headlines, but it is the kind of things that will allow you to be efficient and to be profitable at Medicare reimbursement rates, which is the absolute cornerstone of your revenue and profitability success in the environment we are entering. Finally, you're going to have to get wired if you're not already there, and that means electronic health records, health information exchanges, advanced analytics, all of this to support at-risk payment models which will dominate the hospital and health system environment for the next decade. So what I want to do now is turn my last couple of minutes over to you and ask for any questions that you might have. I'll be happy to address them, and if I don't get to anything, I would be very happy to answer them by email. My email address is down here at the bottom, and thank you very much.
Thank you, Kim. Great presentation. And we did have a couple of questions that came in, mostly around whether the content that you just presented would be available. And the answer is yes. We're recording this session, and we'll send that out in the next couple of days, as well as the documents themselves, so you can review that at your leisure. Like Kim said, we're going to open up to questions, so I'm going to look to see if there's any that have come through on the chat or the Q&A. It looks like we may not have too many questions. What that tells me is you did a great job of covering all the of all the bases.
Well, thanks again, Aaron, for having me. I really appreciate it, and I hope the rest of your meeting is very successful. Thank you very much, ladies and gentlemen.
And it looks like we did have one question come in right here at the end. Could you share once again the organization that you're working with to do the research for your healthcare system data?
Yeah, this is, I'll do this very quickly. I support an organization called Harris Interactive, which was just purchased this year by Nielsen. These are big opinion research companies, okay? Harris Interactive, or now Nielsen, has supported a healthcare forecasting service called Strategic Health Perspectives for the past basically 25 years. We do annual surveys of hospital and health system executives, as you've seen. We also survey health plans, we survey physicians, we survey patients, and we do some informal work with policymakers as well, government and regulatory officials. What we do is we try to tie all those together, and for the Strategic Health Perspectives client base, we try to interpret more or less which way the wind is blowing over a 3 to 5 year period. It's probably as succinct a description as I can give you.
Perfect. And once again, I want to thank Kim for his time and for the great presentation. We see a lot of synergy and the work that he's done and our vision of making hospitals more efficient, more effective. So we thought he'd be a great contributor to this event. And if you have any questions for Kim, you can reach out to him, as he said, at kdsconsulting@verizon.net.